Coming up in this episode, this is the ideal situation because it gives you a massive, massive, massive head start on everything. It is the best thing ever if you get a pre notification. So, how are you going to use this advantage? How are you going to use this advantage to get a better door to needle time? Hello, and welcome to the next installment of Neurology Education, a not for profit, free open access project with a philosophical touch exploring all areas of clinical neurology for medical students through to neurologists and any health professionals caring for patients with neurological conditions. I'm your host, Tom, a neurologist, epileptologist, and neurophysiologist and neuromuscular specialist, and also a physician, philosopher, and bioethicist. Today, we've got a really exciting episode, which I think will be really high yield for all of our listeners, and it's how to run a stroke call / code stroke and decision making regarding thrombolysis and thrombectomy eligibility. And this is the next episode in the stroke and cerebrovascular diseases episode. Before we progress further, a legal disclaimer: the content of this episode is for educational purposes only. Also, any post-publication corrections which I identify will be included in the video and audio podcast descriptions. And I'll say now that there are 2 episodes that I've picked up on a few small-ish mistakes out of the 17 episodes that have been published so far. Firstly, the NIHSS video, when I was listening to it after it was published, I noticed that I didn't really clearly emphasize that the visual threat testing is really only used to assess visual fields when standard confrontational testing is not possible, owing to consciousness or cooperation or language problems. Conversely, if the patient's already completely conscious and cooperative and you've already established that they have a hemianopia, there's no point in doing visual threat testing. And that same video also incorrectly stated upper motor neuron lesion when I meant to say a retrochiasmal lesion when I was referring to the upstream component of the visual pathway as opposed to the motor pathway. And the other episode with a very small mistake in it was the epilepsy definition and classifications video, where I've noticed that one of the slides, or a few of the slides, incorrectly wrote that EIDEE as opposed to EISS is the new term for West syndrome. So, when I get that stroke call page or that stroke call phone call, how do I approach it? What do I do? What is going through my mind? Well, I've been to hundreds, probably about 1,000 of these over the last few years. So hopefully I can communicate to you an effective way to approach this as well. And hopefully you find this interesting and useful for your clinical practice. So the way I think about it is that there are 3 or perhaps 5 main pieces of information that you need to quickly and accurately elicit. And the reason that I say 3 or 5 is there's 3 main things, which are the really, really, really important core things, and then 2 additional things that are really important in terms of determining your pretest probability of the episode being a stroke versus a stroke mimic, and in determining the pretest probability of the mechanism of the stroke, and in terms of identifying any contraindications to thrombolysis in particular. But in terms of really establishing, firstly, whether someone's even an eligible candidate for thrombolysis or mechanical thrombectomy, those first 3 components are going to be the most important. And then there's a few basic things that you need to do at the very beginning as well. So the very basic things, which aren't the 5, are firstly, when you get the phone call and you hear the story very briefly from the person giving the story to you, this is all assuming that what's being told to you is that the patient has symptoms or signs which are actually potentially consistent with an acute stroke syndrome. So 99% of the time they will be. Occasionally the stroke call can be completely mistriaged. So you might get a stroke page or a stroke call, and then what's being described to you is just obviously a seizure or obviously a Guillain-Barré syndrome. And if you were seeing that patient in the emergency department, stroke wouldn't have even entered your mind as a differential diagnosis. So, like, occasionally you might get that obviously mistriage case, but 99+% of the time that's not the case, and cases are appropriately triaged. And the other thing which I'm going to say right at the very outset, before you even get onto your higher level decision making and your higher order thought processes, is get a cannula in. I cannot stress this enough in terms of minutes lost in terms of door to needle times, door to puncture times with thrombolysis and mechanical thrombectomy, so your key performance indicators, your KPIs, one of the things that slows you down the most is just not having a cannula in. So before you even start asking the patient questions, before you even start doing anything else, make sure that the patient has a cannula in. And I'll harp on about that more in a little bit. Now, what are these 3 or 5 core items that need to be elicited? The first one is the time last seen well, and that's given the acronym LSW. The second is what is the patient's baseline function? And that is defined in hyperacute stroke medicine and in stroke medicine generally by the modified Rankin scale, or the MRS. And the third core aspect is what are the patient's current clinical deficits, and that's as defined by the NIHSS, the National Institutes of Health Stroke Scale or Stroke Score. Now, what are the other 2 things? So what's number 4 and 5? Well, number 4 is what are the patient's comorbidities that are relevant in the hyperacute stroke context? So in particular, any previous ischemic or hemorrhagic strokes that the patient's had, whether they have atrial fibrillation, do they have known cerebrovascular stenoses, any vascular or metabolic risk factors? Do they have a history of stroke mimics, for example, epilepsy or functional neurological disorder, FND, or hemiplegic migraine? Is there any past medical history of any contraindications to thrombolysis? And we'll also throw in what is the patient's current blood pressure in this category, because that's very important in terms of eligibility for thrombolysis. And then the 5th point is what medications is the patient on, but specifically, are they on anticoagulations and antiplatelets, and what are the details there? So what I propose we do for the remainder of this video is go through these steps in detail. So when you get the notification, when you get the stroke call or the code stroke, there's a few different types of notifications you can get. You might get a pre-notification, and this is ideal. So that's when you get a pre-notification from the paramedics. So either the paramedics calling you directly before the patient hits the emergency room, or the paramedics call the emergency department staff, and then the emergency department staff call you before the patient's even arrived. This is the ideal situation because it gives you a massive, massive, massive head start on everything. It is the best thing ever if you get a pre-notification. So how are you going to use this advantage? How are you going to use this advantage to get a better door-to-needle time? Well, the first thing is you want to get as much information ahead of time as you possibly can. So get as much information out of the person on the other end of the phone as you can. Sometimes the paramedics may only have limited information. Sometimes they can't even tell you the patient's name sometimes, so you can't always find them on the electronic medical record, but sometimes they will be able to tell you that, and then you can go on the medical record and see if there's any additional useful information that can be elicited. The other thing I'll say here is don't ever trust the stated estimated time of arrival, the ETA. I've been caught out by this more than once, and what I would recommend is just get there earlier than what the ETA says. So if you're in the middle of clinic, or you're in the middle of admitting a different patient and you're on site, or if you're off site and you need to travel into the hospital to get there in time and the paramedics say, we'll be there in half an hour, don't trust the half an hour, get there in 15 minutes, because there have been times when the ETA has been overestimated, and that's the worst thing. If you trust the ETA and then you get there in the time that was stated to you and the patient's already been there for 10 minutes, you've just lost 10 minutes. So that's quite disheartening when that happens. So get there earlier than you think that you need to. Then when you get the pre-notification from the paramedics, please, please, please ask them for a cannula if the patient doesn't already have a cannula. That's one of the most helpful things that the paramedics can do, especially if they've got a half-hour trip from the place where they pick the patient up to the hospital. If they can get a cannula in, that is so helpful because it saves time. It means that the staff in the hospital don't then need to muck around trying to get a cannula in. They can just do all the other steps, and you've just saved some time there. And sometimes it's only a small deal. Maybe the patient's easy to cannulate and they arrive without a cannula and you get one in and you only waste a minute. Not the end of the world. Not ideal, but it's not the end of the world. But if you have a patient who's a difficult cannulation and 2 or 3 people try and they have 6 or 7 attempts and it takes 5 minutes or 10 minutes to get a drip in, that's really, really not what you want. And if the patient could have had a cannula in before they arrive, that's really essential. The type of cannula matters as well, and the location of the cannula. So you want it to be fairly proximal, so ideally in the antecubital fossa, although it doesn't necessarily have to be quite that proximal. It can be a bit distal to that, somewhere in a nice vein in the mid-forearm. But what you don't want is a little spidery vein on the back of a hand. And regarding the gauge of the cannula, ideally you'd have an 18 gauge cannula, although usually a 20 gauge is sufficient. But what you really don't want is you don't want a spindly 22 gauge cannula in the back of the hand, because that just will not be sufficient for the CT angiogram and for the CT perfusion. You really want an 18 or a 20 gauge cannula, which is in the antecubital fossa or at least the proximal aspect of the forearm. The other things that you should do in this golden time that you have before the patient even arrives is to pre-notify the relevant parties if necessary. So if your site does their thrombectomies under general anesthetic, like many of the hospitals that I've worked in, then anesthetics need to be told about the case. So you need to pre-notify the anesthetics department. You need to pre-notify the radiology department and ask them to put the CT table on hold so that there's no delay from getting the patient from the triage area of the emergency department where the paramedics unload the patient straight through to the CT table. And also, if it's likely to be a clot retrieval case, a mechanical thrombectomy case, then you should give the neurointerventionalist a heads up with as much warning as possible so that he or she can prepare a table if they're already on site, or if they're off site, so that they have time to come in, they can stop walking their dog, they can quickly finish up their breakfast and come on in so that there's no delays. Then in terms of what to look on the medical record, if you do have some spare time and you are able to locate the patient on the medical record, you want to know what past medical history do they have, what medications are they on, are there any stated limitations of care, so resuscitation plans, advanced care directives that are already in the medical record, etc. So they're really, really key pieces of information to elicit. Now, the second scenario would be you don't get a pre-notification. So in that context, you don't get any of these above luxuries. But what I would really recommend doing is the second that you walk in the room, before you even ask your first question, before you've even acknowledged the patient and said hello to them, you just want to see if they've got a cannula in or not. And if they don't, you want to delegate that role to somebody else who's competent at cannulating and ask them to get a cannula in. And at the same time, pull off some basic bloods. And in particular, if the patient is anticoagulated, even if they're not, but especially if they are, you want to pull off some coags, so a coagulation profile, and think ahead of time. So if the patient's on a DOAC, then if it's rivaroxaban or apixaban, you might consider doing in fact, I would recommend doing DOAC-specific anti-10A levels for rivaroxaban and apixaban, and for dabigatran, you might consider a thrombin time, although reversal with idarucizumab is an option, and we'll talk to that later. And if the patient's on warfarin, then you certainly need an INR, an international normalized ratio. And if there's any concern about thrombocytopenia, maybe the patient has a history of the same, or maybe they've got chronic liver disease or alcohol dependence or something along these lines, then you'll certainly need a full blood count, a complete blood count, in order to measure the platelet level. So if there's no pre-notification, you walk in the room and the first thing you want to do is see if the patient has a cannula, and a proper cannula at that. And then you want to check that the basic bloods have been pulled off. The other thing that I would say is when you're actually walking to the bedside from wherever you were when you got the stroke call, I would suggest that you walk briskly, but don't run unless you're super fit. And the reason I say this is I've learned this the hard way from experience, that unless you're super fit, if you run, by the time you get to the stroke call, or if you're holding a code blue pager, by the time you get to the code blue, you don't want to be the most hypoxic person there, more hypoxic than the patient. Or for a stroke call, you don't want to be more dysarthric than the patient is when you get there. So you want to get there quickly, but not so quickly that you're useless when you arrive. So in terms of the meat of it, firstly, we want to establish the time that the patient was last seen well. And it's important that we use this framework because this is a little bit different to the time that the onset of the symptoms was first noticed in the context of when the time of onset is completely unknown. So if the patient is just unable to communicate and there was no witness at the time that the symptom onset actually occurred, or in the context of a wake-up stroke. So in these contexts, whenever the symptoms actually began may not actually be the same time as the time last seen well. So if you can't take the patient's word for what they're describing because they're unreliable by virtue of being confused or obtunded or dysarthric or dysphasic, or if they've woken up, then you have to take the time of last seen well. But in particular, regarding a wake-up stroke, there's this nifty thing that you can do, which is called taking the midpoint of sleep. And you can then take that point as your time of last seen well, based on all the clinical studies that have been done. And in doing so, you need to know what time the patient went to sleep and what time they then woke up with their deficits to calculate the midpoint. So for instance, if they went to sleep at 10 p.m. and then they woke at 8, they've been asleep for 10 hours, half of which is 5 hours. So you add 5 hours onto 10 p.m. and you end up with 3 a.m. So that's the midpoint of sleep. But what you also need to do is ask about any overnight bathroom breaks or any midnight snacks or any other reasons that the patient may have woken up overnight. Because if they woke up overnight and they didn't have the obvious clinical deficits that they do now, so for instance, if the patient wakes up with motor deficits with a right hemiparesis, and they didn't have a right hemiparesis when they woke up to go to the toilet, then you can shift the starting point in that calculation forward and save yourself a few hours. So for example, if in the above example that I provided, if the patient actually woke up at 2 a.m. to go to the toilet and they didn't have a hemiparesis and they were totally fine at that time, and you could reliably say that those deficits were absent, then you can recalculate. So you can say, actually, it's as if they went to sleep at 2 a.m. because they then went back to sleep at 2 a.m. and then they still woke at 8 a.m. So actually only 6 hours elapsed, half of which is 3 hours. So 2 a.m. plus 3 hours then equals 5 a.m. So you can take the time of last seen well, or the midpoint of sleep as 5 a.m. as opposed to 3 a.m. in the previous example. So you've just bought yourself an extra 2 whole hours in terms of the time frame upon which the various hyperacute stroke intervention options may be feasible. And so this could be the difference between someone being eligible for thrombolysis and or clot retrieval and them being ineligible for thrombolysis and or clot retrieval. So what are the timeframes that are relevant in the hyperacute stroke context? The first thing to say is that the answer to this question is constantly changing. Every few years, it seems that there's a new landmark study that seems to be released, which stretches the time frame out longer. And that's why it's really important to stay up to date with the literature, especially in stroke medicine. So this is being recorded and filmed in November 2025. And what I'm about to tell you is accurate at the time of writing. But if you're listening to this in 2027 or 2030, then this might not be up to date. So you really need to stay up with the literature. And owing to this, people not being up to date, there's a common misperception I've noticed that people incorrectly think that hyperacute stroke assessment is only for patients presenting with a time of last seen well less than 4.5 hours. But that's not true. So it used to be 4.5 hours, but in November 2025, it most certainly is not just 4.5 hours. So what is it? The way to think about it is in terms of thrombolysis timing windows and then separately thrombectomy timing windows, because they're not quite the same. So for thrombolysis timing windows, you've got your early timing window and your extended time window. So the early time window is between 0 hours and 4.5 hours. And this is all from the time last seen well. So to say it again, the early time window is from 0 to 4.5 hours. And importantly, that's considered the clinical time window. So you're within your grounds and you're within the evidence base to thrombolyze a patient within the early time window, so within 4.5 hours, provided that you've done a non-contrast CT brain and excluded an intracerebral hemorrhage and there's no other contraindications to thrombolysis, etc., etc. But you do not actually need a CT angiogram or a CT perfusion in order to thrombolyze a patient in the early time window. Now, what about the extended time window? So this is between 4.5 hours and, for the most part, 9 hours. And this is when thrombolysis may be an option based on advanced perfusion-guided imaging. So in Australia, that's almost always a CT perfusion, but it could also be an MR perfusion in some instances in Australia or in other places overseas. Now, there's two other points to make here. Firstly, there was a recent study published looking at tenecteplase for thrombolysis all the way out to 24 hours, and that was called the TRACE-3 study. And that was looking at thrombolysis with tenecteplase out to 24 hours, as I just mentioned, if mechanical thrombectomy is not an option. And this was a large Chinese study, and it demonstrated that, yes, tenecteplase was an option. I'm not going to go into too much detail on this paper because there's an upcoming Journal Club episode that I have planned, which is going to do a deep dive episode into this clinical study because it's really important and I think probably practice changing in the future. However, I will say that it hasn't really made its way into most guidelines or into routine clinical practice, at least in Australia in any case yet, but it probably will be coming in the future. I should also say that there's lots of studies that have demonstrated that tenecteplase is better than alteplase, but we won't go into that in this episode. It's also important to say that what about the patient who has a truly unknown time of onset? So if you've got patients who have a clearly known time of onset, that's more straightforward. Or if you have a wake-up stroke and you know when they went to bed and you can calculate the midpoint of sleep, that's also relatively straightforward. But what if someone truly, truly has an unknown time of onset? They're found in the street by a good Samaritan passerby who calls an ambulance, who comes and picks the patient up. They come to the emergency room. No one even knows what their name is. Anything about the patient is completely unknown when they were last seen well or what the time of the onset of their deficits was. Well, there is something that you can technically do in this situation, and it's using an MRI. And specifically, it's looking at DWI flare mismatch. And that was established in a study called the Wake Up study. And what it found was that patients who had DWI flare mismatch, so an abnormal DWI showing restricted diffusion, whereas a normal flare study, that was essentially meaning that the patient was within the 0 to 4.5 hour timing window for all intents and purposes. So even though it's an unknown time of onset, pragmatically we know that it just wasn't witnessed, but actually this is still in the early time window or the clinical time window. So treatment with hyperacute therapies is still reasonable if you have access to an MRI in the hyperacute stroke setting in that context. And we do sometimes do that in Australia if that is the situation that you're in, and I'm sure that's done overseas as well. So we've spoken about the timeframes for thrombolysis. Now let's talk about the timeframes for thrombectomy. They're slightly different. So for the early time window, thrombectomy, it's 0 to 6 hours. So that's not 0 to 4.5 hours, it's 0 to 6 hours. And I suppose that could also be considered the clinical time window. You need a bit more imaging though for thrombectomy because you obviously need a CT angiogram or perhaps an MR angiogram, but usually a CT angiogram to know if there's a large vessel occlusion that you can then fish out with thrombectomy. But you don't need the advanced perfusion guided imaging in that early 0 to 6 hour time window. You may choose to do that advanced imaging anyway, but it's strictly speaking not necessary. Conversely, in the 6 to 24 hour time window, that's considered the extended time window, and that's where perfusion based imaging, so usually a CT perfusion, sometimes an MR perfusion, is necessary. Although somewhat practice changingly and somewhat controversially in some senses, there have been some recent studies which have been large core studies, and they've actually demonstrated that there's benefit for mechanical thrombectomy even when there is a large core, meaning that there may be unfavorable imaging profile with an unfavorable mismatch ratio. So the penumbra may be relatively small compared with the size of the core, and traditional teaching would say that that was not a good candidate for thrombolysis or for thrombectomy because you've already missed the boat, a large percentage of the brain has already infarcted, the penumbra, which is salvageable, is relatively small in regards to the size of the core, and so the risks of intervention are outweighed by any benefits and the risks of reperfusion injury, etc. And the historical teaching would say not to do hyperacute intervention for those patients. But some of these large core studies have contradicted that. So an example would be Select 2, which looked at M1 infarcts specifically between the 0 to 24-hour time window. And actually the median time frame in that study was 9.3 hours from last seen well. So that's actually well into the extended time window. There are some qualifiers here, though, in terms of the technicalities in regards to just how large counts as large, in regards to the core size, how unfavorable really counts as unfavorable in terms of the mismatch ratio, etc. And we don't have time to go into that detail today, but perhaps that could be an episode in the future. Some other comments on CT perfusion imaging is that it can be falsely negative or underestimate the severity of a stroke in the early time window, and it can slow the process down. And I have found that working in quite a number of different hospitals in a few different states and territories in Australia, there is some difference in the way that acute stroke medicine is performed in between different sites that I've practiced at. So some centres, probably more than half of the centres, routinely do a CT perfusion as part of their acute stroke protocol for all patients. But some centres don't do that, and they actually deliberately don't do a CT perfusion in the early time window for thrombolysis means and in the early time window for thrombectomy purposes. And they take a bit more of a case-by-case approach in regards to who to do a CT perfusion on and who not to do a CT perfusion on. I would say that either strategy has pros and cons. The more case-by-case approach has the potential benefit of doing less unnecessary CT perfusions and potentially speeding things up by doing less imaging. But the main downside is that by having a case-by-case approach, it's not as easy to have a blanket policy, which is easy for everyone to understand, and typing in CT stroke protocol and everyone gets the same imaging workup done. That has an advantage by the way of how familiar it is to everyone involved in the process. The other thing is that a CT perfusion can still be helpful even in the early time window, especially if there's diagnostic uncertainty regarding a stroke versus a stroke mimic. So if you think the patient actually has a seizure or FND and you do a CT perfusion, then that can be highly helpful. So if the perfusion pattern is the opposite of what you would expect in a stroke, so if the anatomic territory that you think is dysfunctional shows hyper-PER perfusion as opposed to hypo-PO perfusion, then that could be suggestive of a seizure. Or if the CT perfusion is plumb normal, then that would be supportive of FND, for example. However, you've got to take that with a grain of salt as well, especially in the very early time window. In the first hour or two, you can have completely normal perfusion imaging and you can be misled by that. And also, you have to be careful in the posterior circulation and in the brainstem in particular, because we know that CT perfusion is much less sensitive for posterior circulation changes. So, how are we going to summarize this? How are we going to remember how to think about timeframes in acute stroke medicine? Well, basically, at the time of writing, November 2025, anyone presenting between 0 hours and 24 hours of the time last seen well is a potential candidate for hyperacute stroke management. So all you basically need to remember, between 0 hours and 24 hours is a big green tick. And the other thing is, if a patient has a truly, truly unknown time of onset in an otherwise perfectly good candidate, then that also potentially meets the criteria for consideration if MR is available. Conversely, if the time of last seen well was more than 24 hours ago, then really the patient is not a candidate for hyperacute stroke intervention. Now let's move on to the second big point, the patient's baseline function, the modified Rankin scale. This is a super, super, super important concept, but I notice that it's often misunderstood. So, how do I remember it? How do I conceptualize it? Basically, it's a score from 0 to 6. And the way that I think about it is you can draw this big line in the sand between 3 and 4, because that's where the big difference is in terms of eligibility for hyperacute management. So, 0 is you don't have any symptoms at all. 1 is you have symptoms, but there is no functional impairment. 2 is there is mild impairment in that the patient may not be able to do all of their hobbies and all of their previous activities, but they can still do their activities of daily living, including their instrumental activities of daily living. So, what do I mean by that? They can do their instrumental activities of daily living, so they can still go to the bank, manage their finances, do all those things, but they can't do all their hobbies. So they might not be able to play golf like they used to, or their handicap might have deteriorated with their golf score, for instance. They're not at the same level that they used to be, but they can still function in daily society normally. So that's a 2. Now, what's 3? So 3 is moderate impairment. And basically, this means that the patient needs help or may need help with some instrumental activities of daily living, but they can still do their personal activities of daily living and they can still mobilize independently without requiring help from another person. So, this is where people can be a bit confused. So, firstly, personal activities of daily living, that includes things like dressing, eating, toileting, things like that. And then in terms of the capacity to mobilize independently without help from another person, that means you don't need another person to help you, but it's okay if you can mobilize independently, but you still need the assistance of a walking aid. So you're still allowed to have a walking stick or a four-wheelie walker or a walking frame. That still counts as independent if you can get around on your own without needing another person to help you. It's only when you need another person to walk with you or for you that you don't meet that criterion. So that's all on the green side of the line in the sand. Now let's move on to the red side of the line in the sand. So 4 is the patient needs help with their personal activities of daily living, or they can't mobilize independently without the help from another person. And one tricky thing I'll say here is that the original publications that defined the MRS, they didn't actually use clear Boolean operators in regards to the use of the word and versus the word or, which you must think that's the pickiest thing I've ever said in my entire life, but it's actually really important because it's not uncommon that you'll be at a stroke call and you'll see a patient and they need some help showering, but they can mobilize independently. Are they a 3 or a 4? Well, that depends on whether it's interpreted as that one key word being an or an and. And it's a little bit ambiguous, I must say, but what I would say is that the standard way it's interpreted is that you're a 4 if you need help with personal ADLs or if you can't mobilize independently. And conversely, to score a 3, you need to be independent with personal ADLs and you need to be able to mobilize independently. So I hope that's clear. Then a score of 5 is the patient's completely bedbound. And then a score of 6 is the patient's already dead. And that's really just included for statistical research purposes. Now, one other way that people sometimes conceptualize this is by using another concept of how long could you leave the patient alone for safely. I haven't seen this published. It may be published somewhere and I may have just not read it, but it wasn't included in the original description of how the MRS was actually stated, as I've just mentioned. But just so that you're aware of this concept, some people ask the questions either to themselves or to family members or to the patient, could the patient be left alone safely for a week? And if the answer to that is a yes, then it roughly corresponds with an MRS of 2. And conversely, could you leave the patient alone safely for 24 hours? If that's a yes, then that corresponds with an MRS roughly of 3. Whereas if you couldn't safely leave the patient alone for 24 hours, then that corresponds with roughly an MRS of 4 or higher. So that can be helpful. I find it confusing to some extent. I don't think it really helps that much. But really what this is getting at is is the patient able to do instrumental activities of daily living, and are they able to do personal activities of daily living? So if you can leave someone alone safely for a week, then they're fine with their ADLs. Otherwise, you couldn't leave them safely for a week. And conversely, if you could leave someone safely for 24 hours, then sure, they might not respond to their bank bills and they might not collect their mail, but they're still going to be able to eat and drink and remain in a state of basic personal hygiene. So they're independent with their personal ADLs. Conversely, if you can't safely leave someone alone for 24 hours, then they're not independent really with their personal ADL, so there must be a 4 or higher. So that's what I think that this concept is getting at, but I think it adds a bit of an additional layer of confusion, which is not really necessary. But if you do find that helpful, then you're also welcome to use that as a framework. Now, why have I drawn this firm line in the sand between a 3 and a 4? Well, in practical terms, usually if you're a 3 or lower, then you are a candidate for hyperacute stroke management, whereas if you're a 4 or higher, then you're not a candidate for hyperacute stroke management. Technically speaking, some of the foundational studies were looking at thrombolysis and thrombectomy on an MRS of less than or equal to 2 rather than an MRS of less than or equal to 3. But I would say that other studies and in any case, standard clinical practice and guidelines basically seem to always involve MRS3 in hyperacute stroke evaluation as well. And conversely, although an MRS of 4 or higher is not evidence-based in terms of hyperacute stroke assessment, there are some stroke physicians who, in my experience, may go off-label and may choose to intervene anyway. And that's that individual practitioner's decision. It is important to understand that that's not routine practice, that's not standard or common practice, but it should always be discussed with the decision maker if that's not you, because people may make different decisions based on their own understanding of the literature. So, how are we going to summarize what we just spoke about? Basically, just remember the line in the sand between 3 and 4. If the MRS is 0 to 3, then for all intents and purposes, the patient is a potential candidate for hyperacute stroke assessment and intervention. Whereas if the patient is an MRS of 4, 5, or 6, then going by the book, they are not a good candidate for thrombolysis or thrombectomy. Now, the third point, the NIHSS. I'm not going to go over this again because one of my previous recent videos went through the NIHSS in quite a lot of detail, so please do watch that video if that's something that you're interested in, or listen to that audio podcast. And please note the couple of small corrections that I mentioned at the beginning of the podcast and video of this video. Now, how are we going to interpret the NIHSS score in terms of determining eligibility for hyperacute intervention? Well, again, this is a bit different between thrombolysis and thrombectomy, although it's not that different. So, for thrombolysis, until very recently, really until the last few years, we were treating minor non-disabling strokes with thrombolysis in some circumstances. So anyone really with a NIHSS of 2 or higher, we were thrombolizing sometimes. However, there have been some recent majorly important practice-changing studies that have been released that have demonstrated the non-inferiority of DAP, so dual antiplatelet therapy, compared with thrombolysis for minor non-disabling strokes with a NIHSS of 0 to 5. And importantly, this is based on clinical criteria. It's based on the NIHSS. It is not based on radiological criteria. Somewhat confusingly, the definition of non-disabling varied a bit between the key studies that established this body of literature. So, for instance, the ARAMIS study and the PRISMS study, so the ARAMIS study, and then the PRISMS, the PRISMS study. And it's a bit of a controversial and hot topic as to exactly what counts as a minor non-disabling stroke and what doesn't count as a minor non-disabling stroke. But for all intents and purposes, you need a NIHSS of 0 to 5, and it needs to be not disabling. So it needs to be not impairing the patient's activities. In addition to this, some of the studies also included more specific guidance on this, and they said that the patient can't score more than 1 point on certain key items such as vision, language, neglect, or single limb weakness. and they can't score any points at all on the consciousness item. Thankfully, you don't really need to remember this subpoint. It would be good if you do remember it, but it's not absolutely essential because it's basically common sense. It's very intuitive. So if someone has significant deficits in vision or language or neglect or in limb weakness, then that's clearly going to be disabling. Or if they have any deficit in terms of their level of consciousness, then that's disabling and that's not a minor problem. Whereas if you're only scoring 1 point in one of these areas or more points but not many in some of the other less important areas, then that's going to be more minor and more non-disabling. So I think that is fairly intuitive. Now, what about thrombectomy? So generally speaking, you need a NIHSS of 6 or higher to be a good candidate for thrombectomy because most of the thrombectomy studies have been based on this if we're going to be by the book and evidence-based. And so combining that with the studies on minor non-disabling strokes and DAP non-inferiority to thrombolysis that I just spoke to, that then brings the thrombolysis and the thrombectomy in accordance. So you really want a NIHSS of 6 or higher. It is important to know that this is not always an absolute black and white distinction, also including thrombectomy here. So you could have a patient with a NIHSS of 5 or 4, but it's really disabling and they've got really favorable imaging. The interventionalist may well choose to still take that person to the lab and do a mechanical thrombectomy. But generally speaking, the best evidence base is for a NIHSS of 6 or higher for thrombectomy. The last thing regarding the NIHSS that comes up sometimes is, can the NIHSS be too high? And at least theoretically, there's a risk of hemorrhage or reperfusion edema and hemorrhage, especially with bigger strokes. And the higher the NIHSS, one would think that would correlate for the most part with the radiological size of the stroke. Of course, it matters where the stroke is as well. So you could have a very small stroke radiologically in the brain stem and have a major clinical deficit that corresponds to what would be a much larger stroke in the cerebrum to cause the same deficit. But generally speaking, there's at least a correlation between how high the NIHSS is and how big the stroke is. However, we know now that in the past, we would have said if someone's got a really high NIHSS, then that might take them off the cards for thrombolysis. We now put more emphasis on the radiologic criteria as opposed to the clinical criteria in this circumstance. So what we say is to take an extra close look at the non-contrast CT. Don't forget about the non-contrast CT. So have a really, really close look at the non-contrast CT for if there's an already established hypodensity, indicative of an already established area of infarction of core. And then you can calculate the aspect score if that's something that you're knowledgeable in doing and capable of doing. That's optimal, but you can also get a feel for it. If someone's got a large area of the brain which is hypodense on the non-contrast CT, then you've probably missed the boat in the context of someone with a high NIHSS, and that's not going to be a good candidate for thrombolysis, and they're going to be a very high risk of hemorrhage following thrombolysis. The other imaging criterion which is helpful here is a CT perfusion with a very unfavorable core to perfusion ratio. Although, again, this isn't considered an absolute contraindication, and remember some of the large core thrombectomy trials in particular that we mentioned earlier this episode. The other thing is that someone could have a very high NIHSS clinically, so into the high 20s or into the 30s, but if they have favorable imaging, so if they don't have an established hypodensity, a large hypodensity on the non-contrast CT, and if they have favorable perfusion imaging, then they can still be thrombolyzed and clot retrieved despite having a high NIHSS. Now, moving on to number 4 and 5 in the 5 things to remember. These are the comorbidities and the medications, specifically the antiplatelets and the anticoagulation. So, as I mentioned at the beginning, these are really geared at determining a few things. Firstly, the pretest probability of this being a stroke versus a stroke mimic, in determining the pretest probability of it being an ischemic stroke versus a hemorrhagic stroke, and also the mechanism for the stroke and the anatomy of the stroke, and crucially, determining any contraindications, both absolute and relative, to thrombolysis and also to thrombectomy. So, what comorbidities are we interested in? We don't need to know about everything, but the ones that we are interested in are things like previous ischemic or hemorrhagic strokes, atrial fibrillation, known cerebrovascular stenosis. So if the patient has nasty ICAD or they've got a known 85% left ICA stenosis, you want to know about that. Any vascular or metabolic risk factors. So does the patient have hypertension, type 2 diabetes mellitus, or type 1 diabetes mellitus, dyslipidemia, obesity, smoking? Do they have a history of stroke mimics? Do they have a diagnosis of epilepsy or of FND or of hemiplegic migraine? And importantly, is there anything in the history which is a contraindication to thrombolysis? So, for example, neurosurgery, whether that be cranial or spinal in the last 3 months, or significant head trauma or stroke of any variety in the last 3 months, an intracerebral hemorrhage ever, possibly excluding remote traumatic subdural hematomas, for example, any known intracranial malignancy, whether that be primary or secondary solid organ malignancies or hematological malignancies, any significant cerebral aneurysms. So a very small cerebral aneurysm, a few millimeters, is probably not significant, but if you've got an aneurysm approaching the 7, 8, 9, 10 millimeter mark or into the centimeters, then many people would consider that to be a contraindication, an absolute contraindication to thrombolysis. Any significant other vascular malformations, any active internal bleeding or non-compressible bleeding, any suspected or confirmed infective endocarditis, factors that could suggest a bleeding diathesis or a thrombocytopenia. So, for instance, I can think of an interesting case I saw about 12 months ago, a patient who otherwise would have been a good thrombolysis candidate, but they did have a history of problem alcohol use and a hint at some further additional liver problems. So we decided to wait for the platelet count to come back when in other patients we wouldn't do that. And actually the platelet count did come back confirming thrombocytopenia with platelets well below 100. So that patient was not a candidate for thrombolysis. So it's always important to check platelets and coagulation profile if there is a suspicion of an underlying bleeding diathesis or a condition that could be associated with a bleeding diathesis. Any marked hypo or hyperglycemia, mainly because these can be stroke mimics, any gastrointestinal malignancy because these bleed a lot as well, any gastrointestinal hemorrhage in the last 21 days, any major surgery in the last 2 weeks, genitourinary hemorrhages in the last 21 days, recent arterial puncture in non-compressible sites, recent lumbar punctures, post-myocardial infarction pericarditis, because that is a risk factor for a hemopericardium and subsequently pericardial tamponade and death. So all of these factors are really, really, really important to screen for when you're deciding whether it's safe to thrombolyze someone or not. It can be hard to remember them all. So I usually just use a checklist on my phone. I usually go to the MD Calc checklist, or better still, if you have your local hospital or facilities thrombolysis checklist on your phone, the thrombolysis protocol on your phone, and you can just pull up your local institution's list of thrombolysis contraindications and just run off them by the bedside when you're deciding whether to thrombolyze or not. That's what I'd recommend. There's a few others as well, so it's important to know what the patient's current blood pressure is to make sure that the blood pressure is within the safe thrombolysis targets. Some other aspects of the history that are relevant are, does the patient have chest pain or other symptoms or signs even that could be associated or suggestive of, I should say, a stroke related to an aortic dissection, because an aortic dissection is an absolute contraindication to thrombolysis. Is the patient pregnant, which could be a relative contraindication to thrombolysis? Was there a seizure at the stroke onset, which could suggest either a hemorrhagic stroke or a really nasty ischemic stroke with edema, or just epilepsy manifesting as a stroke mimic? So that's a relative contraindication to thrombolysis, a seizure at stroke onset, for instance. It's important to notice, or to recognize, I should say, that the list of these contraindications, they do vary from publication to publication. So different guidelines, different stroke protocols, different bodies, they'll state the relative and absolute contraindications slightly differently. Usually there's major overlap and there's only a small amount of difference between each list, but there is some difference between the lists, and that can make things tricky. And I would say that a lot of these contraindications do carry quite a lot of grey area in borderline cases. And especially when you have a few relative contraindications that are added on top of each other, that's where a lot of grey area in terms of the benefits versus risks of thrombolysis can be quite challenging. And in my opinion, this is by far, by far the most challenging aspect of decision making in hyperacute stroke medicine is when you have a grey area in terms of a contraindication to thrombolysis, or you have no absolute definite contraindication on its own, but you've got three relative contraindications and they're really starting to stack up, and you think, oh gosh, should we really be thrombolizing this patient? That, in my really quite strong personal opinion, is what makes hyperacute stroke medicine difficult. The rest of it, I think, is much more straightforward, but this is where it's really challenging, and that's where experience really helps, and getting the input from an experienced stroke clinician, if that's not you, is really essential. Now, moving on to the antiplatelets and anticoagulation, a few things to say here is that it's mainly relevant in determining the patient's candidacy for thrombolysis, whereas thrombectomy is okay on these agents. So firstly, dabigatran. This is reversible with idarucizumab, and that's really good to know. And that's actually one of my own reasons for quite liking dabigatran when I'm choosing an anticoagulant for atrial fibrillation. For instance, there's other factors that you need to take into consideration, of course, but I'm quite partial to dabigatran. I like dabigatran for that reason. It's the reversible DOAC. So if a patient comes in and they're on a DOAC, I find myself anyway crossing my fingers that it's going to turn out to be dabigatran, and if it is, then I'm like, yes, good. I've got an option to reverse this agent. And when it turns out to be apixaban or rivaroxaban, then my heart sinks because there's no easy way to reverse it. So moving on to apixaban and rivaroxaban, these are potentially reversible with the reversal agent, which is andexanet alpha. However, this reversal agent is much more finicky and difficult to administer than idarucizumab. It's an infusion, it doesn't work as perfectly, and it is not standard practice to reverse apixaban or rivaroxaban with andexanet alpha in order to then thrombolize a patient. When I was preparing this episode and I was developing the content for this episode, I did come across some case reports of instances where andexanet alpha had been used to reverse apixaban or rivaroxaban in order to then permit thrombolysis, but this is at a case report level. It's not standard clinical practice to do this. What about other anticoagulants? So enoxaparin, potentially reversible with protamine, but again, pragmatically, it's not standard practice to attempt to reverse enoxaparin with protamine and then to thrombolize, largely because protamine just isn't as effective as a reversal agent. Theoretically, it may also be feasible to reverse unfractionated heparin with protamine and then to consider thrombolysis. I can't say that I've come across that personally. Maybe you might come across it, but this is not something which is standard routine clinical practice. Warfarin. So, warfarin thrombolysis is possible if the INR is less than or equal to 1.7. So that's the number to remember. 1.7 is the cutoff, and on the line is still in. You're still green. If you're on the line at 1.7, then you can still thrombolize based on what is usually stated as the cutoff. What do you do if the INR is greater than 1.7? Again, it's not that easy to acutely reverse warfarin for the purpose of then thrombolizing in a timely manner. It might be attemptable by giving factor concentrate combinations such as prothrombinase as a reversal agent for warfarin, and then thrombolizing might be possible with serial coag measurement. I can't say I've ever seen that done successfully. That might be something that you might consider, but it's not something which is commonly done. The other thing would be just an awareness that vitamin K works way too slowly, so that's not really going to be an option. One other thing to say about all of this is that, contrary to what has always been understood and taught, there's been some recent observational studies that counterintuitively have actually shown that thrombolysis is actually totally okay on patients who are on therapeutic anticoagulation. And in fact, these patients did better than the patients who were not on therapeutic anticoagulation, which is mind-boggling. However, it's also important to recognize that this really hasn't made its way into clinical practice guidelines yet, and it seems that most bodies are really waiting for randomized controlled trial level evidence, so experimental randomized evidence first before implementing this into their clinical management pathways. And there are clinical trials underway looking at this, so watch this space. Also, I should say that this is all in regards to therapeutic level anticoagulation. If someone's on prophylactic level anticoagulation, such as being on prophylactic enoxaparin, so 20 or 40 milligrams a day just for DVT prophylaxis, then that's totally fine and that patient can be thrombolyzed. We're talking about therapeutic anticoagulation here. Lastly, antiplatelets. So antiplatelets are not a contraindication to thrombolysis in monotherapy or in combination therapy, but it may slightly elevate the risk of bleeding. So that is something that may factor into your, and should at least partially factor into your benefits versus risks weighing up that you'll have to do on a case-by-case basis. And importantly, antiplatelets should be withheld for 24 hours following thrombolysis. So whether you're commencing them for the first time or whether you're recommencing them in a patient who is already on them, if you're going to thrombolyze someone, you need to wait 24 hours before giving them the next antiplatelets. So this is the last substantive slide here. Just a few more points regarding, firstly, decision-making for thrombectomy additional to what I've already said. Mainly, this comes down to anatomical factors. So what blood vessel can you actually get to with the device to do the thrombectomy? So for your standard LVO, your large vessel occlusion, fair game is the ICA, the internal carotid artery, the M1, so the first branch of the middle cerebral artery, the proximal dominant M2, or the basilar artery. Usually, the other feasible sites regarding LVOs are the A1, so the anterior cerebral artery, first branch, first part, I should say, or the P1, so the posterior cerebral artery, first part. So that's usually all fair game in terms of accessibility for intervention. The more challenging or the more controversial and ongoing active study sites are the MEVOs. So as opposed to an LVO, we're talking about a MEVO, so a medium vessel occlusion. So that's all other M2s, so distal M2s or non-dominant M2s, M3s, A2s and A3s, and P2s and P3s. So these all have clinical trials that are underway, and I would basically just suggest discussing this with your INR on call every time. You're going to need to discuss any thrombectomy case with the INR on call anyway, but if you're not sure whether the proceduralist will be able to get to, say, a distal M2 or a proximal M3 or a proximal A2 or a proximal P2, don't just not call them because you think they won't go for it. I would recommend just making the phone call and saying, look, this is going to be a tricky one. I've got a pretty distal M2 or I've got a proximal A2 for you. What do you reckon? Can you have a look at the imaging and let me know what you would like to do? So just make the phone call and see what they think. The other thing that comes up a lot is what happens if the patient is presenting to your hospital and your hospital is a thrombectomy capable center and the thrombectomy is good to go. Should I still thrombolyze the patient or should we skip the thrombolysis and just go straight to the thrombectomy? Or even if it's not a thrombectomy capable center, but you're just down the road and it's going to be a fairly short transfer time, should I thrombolyze as well or should we just skip that and go straight for the thrombectomy? So again, I won't go into too much detail on this because I've got a whole separate episode in our Journal Club series, which is going to be looking at this question specifically and 3 studies that looked at this. But the short answer, so the spoiler, is yes. Basically, you should still thrombolyze even if thrombectomy is available. Now, that's assuming that one doesn't delay the other. So you don't want to delay thrombectomy just so that you can thrombolyze someone. But if you can get the thrombolysis in quickly, then you should do that before or simultaneous with the steps involved in organizing the thrombectomy. Taking a little bit of a philosophical stance here, you could ask, How is it possible for one not to delay the other? How is it possible to thrombolize someone without delaying the thrombectomy? Isn't it by definition going to be delaying it? I think that in practice, there are many instances in which actually it doesn't delay it because there are still steps being taken to organize the thrombectomy, so you may as well just thrombolize them while those steps are being taken. And I think you could allow a bit of acceptable wiggle room here if it's only going to add 1 or 2 minutes to quickly draw up the lysis and get the bolus in, if you're using antiplatelets and then get the infusion running just as they're being shipped off. If that delays things by 1 minute, 2 minutes, 3 minutes, I think that's small enough to say it doesn't significantly delay the thrombectomy, and so you should still go for it. But if there's an anticipated significant delay, then sure, in that case, you can skip the thrombolysis and go for the thrombectomy. But if one's not going to delay the other, then you should do both. I will say that this is a very common and a very controversial source of disagreement between the neurologist and the interventional neuroradiologist pretty frequently. So it's pretty often that this question comes up and the neurologist says, yep, thrombolize, and the INR says, no way, don't you thrombolize, just bring them straight to the lab. I don't want the lysis on board, I just want to do my procedure. And there seem to be somewhat heated arguments about this on a not infrequent basis, but that is what the evidence says. My understanding as to why interventional neuroradiologists sometimes prefer the thrombolysis not to be on board is that the higher bleeding risk makes the procedure then more difficult for them, and also the thrombolysis can break up a big, nice, juicy clot into a bunch of smaller clots that then propagate distally and are then harder to fish out, and so they're post-procedural outcomes in terms of TICI scores, and that's a radiological reperfusion score, might not look as good on paper, so a more difficult procedure. I can understand where they're coming from, but in terms of patient-focused outcomes, the studies do demonstrate that they do better if you thrombolize first and then do the thrombectomy, provided that the thrombolysis doesn't delay, or at least doesn't significantly delay, the thrombectomy. So that's all I had time for today. Thank you so much for tuning in. Please do like, comment, and subscribe because it really, really helps the channel as a whole enormously. And please tell all your colleagues and friends and family and students because I'm really trying to spread this around. Visit our website, rneurologyeducation.org, for all of our media formats and additional content. You can find our video presentations on YouTube and our audio podcasts wherever you listen to your podcasts, and also join us on your preferred social media platforms, all at the domain at rneurologyeducation. And if you would like to subscribe for updates of when new content is released, please email us on contact@rneurologyeducation.org. From cortex to curiosity, this has been Risfeld Neurology Education. Until next time, keep calm and synapse on.